Hello there, welcome to Shine Tech's YouTube channel. In this video we're going to look at heart failure. So in my playlist of pathology of the heart, we are going to look at heart failure followed by congenital heart diseases and ischemic heart diseases, arrhythmias, hypertensive heart diseases, valvular heart diseases, and finally we are going to look at cardiomyopathies and myocarditis. But in this video we are going to look at heart failure. So what is heart failure? So heart failure is also called congestive heart diseases or congestive heart failure, and this is it occurs when the heart cannot generate sufficient output to meet the metabolic demands of the tissues. So we have our heart failing to generate sufficient output. So the blood supplied to the tissues, oxygenated blood supplied to the tissues, is not adequate, okay? Or if it does so, then can only do that at a higher than normal filling pressure. So that is what we call heart failure. The heart is failing to generate sufficient output to meet the demands of the tissues. The tissues are starving out of oxygen. So etiology, the cause of this condition, so we have multiple causes of heart failure, and one of them is that heart failure is as a consequence of increased tissue demand. So we have increased tissue demand as in hyperthyroidism. So if we have an increased tissue demand, the heart will be triggered to pump more, okay, to pump more, and that can lead to heart failure. And apart from that, we have decreased oxygen carrying capacity as in anemia. So if we have less oxygen carrying capacity, what will happen is that the blood which will be pumped to the tissues will have less oxygen. So the heart will be triggered as well to pump more blood so that the tissues receive more oxygen, and that will cause heart failure. Okay, so we also have other causes such as systolic and diastolic dysfunction. So if we have anything that can lead to systolic or diastolic dysfunction, then we are going to have heart failure. That will result in heart failure. So let's see what can cause systolic and diastolic dysfunction. So systolic dysfunction is simply inadequate myocardial contractile function. So here we have the myocardium which is failing to contract. It is not contracting adequately, and that is what we call systolic dysfunction. And diastolic dysfunction is inability of the heart to adequately relax and fill. So if the heart is failing to relax and fill, that is what we call diastolic dysfunction. So here we have the left heart, the right heart, and the left heart. So we have the left ventricle and the right ventricle. So if this part here, which is the left ventricle, which pumps blood to all parts of the all parts of the body through the aorta, is failing, okay, is failing to contract adequately, that is what we call systolic dysfunction. And if this part, which is the right ventricle, is failing to relax so that it accommodates more blood and pump it to the lungs for oxygenation, if it fails to relax more and accommodate an adequate or normal volume of blood, that is what we call diastolic dysfunction. So what is the cause of systolic and diastolic dysfunction? So the cause of systolic dysfunction can be ischemic heart disease. So ischemic heart diseases can cause diastolic dysfunction. So there we have in the left ventricle here, the myocardium, we have sufficient supply of oxygen to these cells, and they start dying. So if they are starving if they become ischemic, then that will lead to an inadequate contraction of the left ventricle, and that will lead to this systolic dysfunction or hypertension. So hypertension can also cause systolic dysfunction in such a way that if we have high pressures in the aorta there, meaning the heart has to work more, it has to pump blood with higher pressure, more than that pressure which is in the aorta, and that will lead to heart failure. Okay, so diastolic dysfunction can be caused by massive left ventricular hypertrophy. So if the walls of the left ventricle becomes larger, okay, so we have the walls of the left ventricles here becoming very large, such that it accommodates less blood. So the blood which is being accommodated here will be less. So the blood which will be pumped in the aorta will be less, and the left ventricle will receive less blood because it receives the blood which is pumped from the left. So what will happen is that even the left ventricle will pump less blood to the lungs, and that will lead to diastolic dysfunction. So we also have myocardial fibrosis. So if you have fibrosis in the layer here in the myocardium of the of the right ventricle, here we have fibrosis taking place, then the myocardium won't relax properly. We said here it is failing to relax. So we have fibrosis, then the myocardium is not relaxing properly, and that will cause this diastolic dysfunction. Amyloid deposition of certain chemicals, certain masses in the myocardium can also can also cause disturbances in the relaxation of the myocardium, and that can cause diastolic dysfunction. We have constrictive pericarditis. Okay, so constrictive pericarditis can also cause diastolic dysfunction. Okay, so now what we should know again is that diastolic dysfunction approximately causes 1/2 of congestive heart failure. So it is one of the most cause of congestive heart failure, and it is most frequent in older adults and also diabetic patients, and in women it is very common. Other causes, we have valve dysfunction, as due to, for example, due to endocarditis or calcification of the valves can also cause heart failure. For example, if we have these valves here being inflamed, so the heart won't be pumping blood properly. The valves are not opening properly due to the inflammation, so that can lead to what we call heart failure. And rapid increase in blood volume can also cause heart failure. We also have increased blood pressure, as in hypertension. Okay, so those were the causes of heart failure. Now let's go and now move on to what we call pathogenesis. How does heart failure takes place? So when the heart is failing, as we have already explained in the etiology, in some of the causes, when it fails, it won't be able to efficiently pump blood. Okay, it won't be pumping blood properly, so that will result in increase in end diastolic ventricular volume. So the volume of the ventricles will increase. Okay, so it is not pumping the blood properly, so blood will start accumulating in the ventricles. Okay, in the ventricles. So that is what we call increase in end diastolic ventricular volume, and we are going to have an increased end diastolic pressure. So end diastolic pressure will also increase, and we will have elevated venous venous pressures. Okay, so let's try to see what we are talking about here. So what I'm saying is that if the heart is failing to pump blood, we are going to have an increase in end diastolic ventricular volume. So we are going to have an increase in end diastolic ventricular volume, and that will lead to increase in end diastolic pressure, and we are also going to have elevated venous pressure. So what we are saying is that the ventricles will pump blood in the pulmonary circulation. So there, since we have accumulation of more blood here, blood will start accumulating as well there. They increase end diastolic pressure. So the pressure here is also going to increase. So once we have increase in the venous circulation there, what will happen is that we are also going to have increase of blood in the pulmonary circulation as well as in the venous circulation of the lower extremities. Also, the pressure is going to increase there. So that, as a result, it will lead to inadequate cardiac output. So cardiac output will be affected because the pressure is increasing. So this inadequate cardiac output is what we call forward failure. Okay, that is what we call forward failure. And also this forward failure is accompanied by increased congestion of the venous circulation. So the venous circulation will be congested. So this congestion in venous circulation is what we call backward failure. Okay, so now the problem here, the root problem in congestive heart failure is deficient cardiac function. So the cardiac muscles is not the cardiac muscle is not functioning properly. That is the root problem. Okay, so everything is just pointing to the function of the myocardium. So here in heart failure we have deficient cardiac function, and as a result of that deficient cardiac function, all other organs will be affected. All other organs will be affected as a result of forward or backward failure. So in backward failure, where we have increased congestion in the venous circulation, we are going to observe the lungs being congested there. We are going to observe edema, and also in the liver, due to venous circulation which is compromised, we are going to have accumulation of blood, which will also lead to accumulation of water in the interstitium, and also we are going to have spleen, which is also going to be affected. That's why they are saying other organs will be affected by this deficient cardiac function. Okay, so now since we have this problem here, the heart will try to compensate. It will try to sort out the problem, to correct the problem. So some of the compensation mechanisms which are brought about here in heart failure, one of them is what we call the Frank stirring mechanism. So this Frank stirring mechanism, so what happens in Frank stirring mechanism is that we have increased end diastolic filling. Okay, so we have increased end diastolic filling. So in the heart here, we have an increase in end diastolic filling. So the filling of the right ventricle here is increased. So once it is increased, the sarcomeres, okay, will be extended more. Okay, that mechanism of contraction, the mechanism of contraction where the myosin and actin filaments interact, pulling the actins toward the midline. the sarcomeres will cause the sarcomeres to extend due to higher ventricular filling there. So since we have extension, more than normal extension of the sarcomeres, what will happen now is that the myofibers will be stretched more, okay, and now the lengthened fibers will contract more. So what I'm saying is that once the sarcomeres are extended more, even the contraction will be increased, will be forcibly, okay, and that will increase the cardiac output. So this is a mechanism which is applied to compensate for the failure of the heart, where the volume, the end diastolic filling of the left ventricle is increased. Okay, so that increase will stretch the myofibers. Now the stretched myofibers will lengthen the fibers there, the acting and filaments. The sarcomere will be increased, will be lengthened. So once it is lengthened, even the contraction will be more forcibly. So if the contraction is more forcibly, the cardiac output will be increased. So that is a compensation. So more blood will be supplied to the tissues. Then apart from this, the flank steering mechanism, we have other compensation mechanisms, such as activation of the neurohumoral system. So here we are talking about neurohumoral system, where we have hormones which are released. We have the neurotransmitters, norepinephrine, which is an autonomic nervous system neurotransmitter. So once it is released, the heart rate will be increased. If the heart rate is increased, even the cardiac output as well will be sufficient. So the supply of blood to the tissues will be now sufficient. Then apart from the release of neurotransmitters, we have activation of the RAS. So as the blood is passing through the kidney, the juxtaglomerular cells are going to detect the lower volume or the lowered blood pressure in there, and once it is detected, renin will be released. Renin will activate angiotensin 1, and angiotensin 1 will be converted by angiotensin converting enzyme, which will convert it to angiotensin 2. So angiotensin 2 will activate or will stimulate the adrenal gland to release aldosterone, which will cause sodium retention, and where sodium is retained, water also will be retained in the blood. So once water is retained in blood, the volume will increase, thereby compensating for the problem, okay, and that will increase vascular tone. Okay, so apart from that, we also have the heart will also try to release the arterial natriuretic peptide. So this one is just released to balance the RAS system. So the RAS system, which is the renin angiotensin aldosterone system, is balanced by this hormone which is released by the heart. Okay, another mechanism here, we also have the myocardial structure changes. Okay, myocardial structure changes, and one of the changes is as a result of pressure overload state. So if the pressure is increased in the heart, what will happen is that we are going to have new sarcomeres which are going to be added. Okay, are going to be added, and those sarcomeres are going to be added parallel to each other. For example, if you have a sarcomere here, okay, this is a sarcomere, and another one will be added. If the pressure increases, it's going to be added this side, just like that, parallel to each other. So we had the first one, and then the second one will be added like this. Okay, so a sarcomere is simply a contractile unit of the muscle, so they'll be added parallel to each other. That is in pressure overload state. So once they are added, what will happen is that we are going to observe hypertrophy. So the thickness of the heart will increase. Okay, so once the thickness is increased, the volume of the chambers there are not increased. Okay, so the volume will be less there, and that will also lead to other consequences. But as a compensation, since we have a higher pressure, more especially in the aorta, if you have higher pressures there, meaning the heart has to pump blood with higher pressure more than that one which is in the aorta. As a result, the sarcomeres will be added parallel to each other, and that will cause hypertrophy of the heart muscle. So apart from in the consequence of pressure overload, we can also have volume overload state. So in volume overload state, the sarcomeres are added in series. So if you have a sarcomere ending from here like this, another one will be added this side in series. So as a result here, we are not going to observe muscle thickness, but what will happen is that the heart is being atrophied, but the thickness is just the same, and it might look normal, but it is increasing in size, and that can be observed here. Okay, so it's just dilating, it's just becoming big. So this is a cross section of the heart. They have cut the heart in the horizontal section. Okay, so we have seen that the ventricles have dilated, have become larger in size due to the volume overload. So the sarcomeres are just being added in series in this case. Okay, but in here the thickness is increasing due to the sarcomeres added in parallel. So you can differentiate what might be the problem in these two diagrams here. So here it is in pressure overload state, where the sarcomeres are added in parallel, leading to increase in thickness of the myocardium, and here it is in volume overload. So in volume overload, the sarcomeres are added in series. Okay, but now for you to confirm that there is something which is going on, you have to measure the heart weight. Okay, because you won't observe any thickness, but if you measure the heart weight, you are going to observe that the heart weight has increased. That's when you are going to know. Okay, so that the heart weight is the best measure of hypertrophy in volume overload hearts. Okay, so now what are some of the consequences of compensation in heart failure? So we have talked about three consequences here, compensations. So we have myocardial structural change, where we have thickness, increase in the thickness, and in that is in pressure overload states, and in also in volume overload state, where we have sarcomeres increasing in length, okay, which are added in series. Then apart from myocardial structural changes, we have compensation such as activation of the neurohumoral system, and we also have the Frank stirring mechanism. So these are the three compensations which are activated in heart failure. Now, what are some of the consequences of compensations? Okay, so the consequence is that oxygen requirement by the myocardium will be amplified. So if we have muscle thickness here, meaning the size of the myocardium is increasing, so I mean the demand for oxygen also increase. So since we have the demand increasing, that will be a consequence. Why? Because what we should also know is that as the mass is increasing, the thickness is increasing, the capillaries in pathological conditions is not accompanied by that increase. As a result, we are going to have oxygen demand will increase, and if it increases without capillary formation, then that will lead to ischemic injury. Okay, so the myocardial capillary bed does not expand in step with the increased myocardial oxygen demands. Okay, that now will lead to ischemic injury. Then apart from that, hypertrophy also typically is associated with altered patterns of gene expression. So we have increased formation of the new sarcomeres in the myocardium. So since we have an increase there in formation of new sarcomeres, we might have altered patterns in gene expression. So these altered patterns can contribute to change in myocyte function, and that can lead to increased heart rate and the force of contraction. Okay, so both of which may improve cardiac output, but also it can lead to higher cardiac oxygen consumption. Okay, so we have an increase in myocytes which are being formed, and since the genes here have been altered, we might have more than what is required. The myocytes will be expressed more than what is required, and if we have increased number of myocytes, then we are going to have higher cardiac oxygen consumption, and that will be a problem. So in the face of ischemia, which we have already talked about there, and chronic increase in workload, other pathologic changes eventually will be seen. Okay, so if we have ischemia, what will happen is that we are going to have myocyte apoptosis. Okay, so the myocytes are not supplied with oxygen, so that will activate apoptosis cascade and they will die. And then apart from that, we are going to have cytoskeletal alterations, and we are going to have increased extracellular matrix. So where we have ischemia, we are going to have increase in extracellular matrix deposition. Okay, so these are the consequences which will be observed. Okay, so in pathologic compensation, okay, cardiac hypertrophy is correlated with increased mortality. So in most cases, these patients die. But now let's now compare this pathologic hypertrophy to aerobic exercise, which is physiologic hypertrophy. Okay, we have said hypertrophy is not good, but why is it that it is recommended in physiologic? You exercise and then your heart becomes large, the thickness will also increase. Now in physiologic hypertrophy, what is happening is that the capillaries are also accompanied by that increase in size, increase in mass. The capillaries which supplies the blood to that to the tissues, to the myocytes, is accompanied, okay, by that increase. And also we also have when resting, the heart rate also decreases and the blood pressure will also decrease when you are resting, but when you exercise it is going to increase. But now in heart failure, even when you are resting, it is always high. It is always high. That's why in pathologic compensation or in pathologic hypertrophy, it is not good, but in physiologic hypertrophy it is nice, it is good. Why? Because it is accompanied by capillary density, and also when you are resting, the heart rate will decrease and also the blood pressure will decrease. Okay, so thank you so much for watching. Don't forget to like, subscribe, and leave your comment in the comment section below.